Hi, this is Bashar Qumseya. I'm an associate professor at the University of Florida in Gainesville, Florida, and I'm here to discuss with you our most recent article published in GIE titled The Prevalence of Barrett's Esophagus Post-Sleeve Gastrectomy, a Systematic Review and Meta-Analysis. I would like to thank GIE for giving us the chance to discuss this very important topic. I initially became aware of this problem, interestingly, through my dentist. When I would go for my regular checkups and cleaning, my dentist, who knew I was a gastroenterologist, told me on several occasions about patients that he had seen who had some sort of bariatric procedure, which he was not aware exactly which procedure they had, and that they had severe reflux, that it was causing severe erosions in their teeth. And he encouraged me to look into this further. So I did some research and found that sleeve gastrectomy, in fact, has been associated with reflux or worsening of reflux. And so this is how I initially became interested in doing this study, and that's when I approached the rest of our research team, including some of our bariatric surgeons here at the University of Florida, to conduct this systematic review and meta-analysis. The main results of our study showed that the pooled prevalence of having Barrett's esophagus after having a sleeve gastrectomy was 11.6%, with a low heterogeneity of only 28%. This means that in all these studies, mainly in the long-term follow-up studies, the prevalence of Barrett's esophagus is much higher than expected in the general or low-risk population. Furthermore, we wanted to look at the association between the prevalence of Barrett's esophagus and reflux. And when we looked at studies that assessed patients and reported Barrett's esophagus in patients who had reflux versus Barrett's esophagus in patients who did not have any reflux, there was no association, meaning that the presence of reflux was not really necessary, or symptomatic reflux was not really necessary for some patients to develop Barrett's esophagus who appear to have developed it regardless of the presence of reflux symptoms. And on a logistic meta-regression analysis, again, we found no association between reflux symptoms and Barrett's esophagus in these patients when controlling for mean age and mean follow-up. So other secondary outcomes that we wanted to look at included the presence of erosive esophagitis. And in long-term studies and long-term follow-up studies, we found that there was an 87% increase in the risk of developing erosive esophagitis in long-term studies, meaning 3 years and after, in patients who had sleeve gastrectomy. And we furthermore did a logistic meta-regression analysis and found a linear relationship between the prevalence of esophagitis and the time after follow-up. This indicated that for each year after sleeve gastrectomy, the prevalence of erosive esophagitis appeared to increase by about 8% each year. And lastly, we wanted to look at the prevalence of reflux symptoms after sleeve gastrectomy. And this was reported in some of the studies, and again, this was a secondary analysis and is not the main outcome of our study, and therefore the search was not done for this particular outcome, yet we looked at it as a secondary outcome. And we found that in all of the studies, there was an increase in the number of people who had reflux symptoms, regardless of the definition of reflux, post-sleeve gastrectomy. However, heterogeneity was so high that we could not come up with a pooled outcome, and the odds ratio ranged from 1.9 to 49. We also looked at the number of studies that looked at patients who developed de novo reflux symptoms. So meaning the patients were assessed for reflux before having surgery and they did not have reflux symptoms. They were assessed for reflux symptoms after having surgery and they had reflux. And this was found to be in a pooled prevalence of 45%. So 45% developed de novo GERD or reflux after the surgery when they did not have it before surgery. Additionally, only 2 studies reported on the use of PPIs before and after, and both of them reported that the use of PPI increased after the sleeve gastrectomy compared to before. In conclusion, we conducted the systematic review and we found that patients who had sleeve gastrectomy are at an increased risk of having Barrett's esophagus. We believe that the prevalence of Barrett's esophagus in long term is about 11.6%. Therefore, we think that these patients should be considered for possible screening for Barrett's esophagus. Additionally, in secondary outcomes, we find an increased risk of erosive esophagitis, increased risk of GERD, including de novo GERD, and also some evidence for increased use of PPI. I think that patients, primary care physicians, bariatric surgeons, and of course gastroenterologists should be aware of this increased risk of Barrett's esophagus and of course the inherent risk of esophageal adenocarcinoma among patients who had sleeve gastrectomy. These risks need to be discussed with the patients in details before they undergo a sleeve gastrectomy. Interestingly, for gastroenterologists, we don't know if endoscopic sleeve gastroplasty is also associated with an increased risk of reflux, since it mimics patients who have sleeve gastrectomy. We think that this should be studied in randomized trials and retrospective or prospective studies to assess patients who have endoscopic sleeve gastroplasty and make sure they are not having similar outcomes, i.e. increased prevalence of reflux, esophagitis, and ultimately Barrett's esophagus and esophageal adenocarcinoma. Thank you so much for listening, and if you have any questions, please do not hesitate to contact me on my email listed below.